Good morning, good afternoon, and good evening. The World Health Organization defines brain health as the state of brain functioning across cognitive, sensory, social, emotional, behavioral, and motor domains, allowing a person to realize their full potential over the life course. And this is irrespective of the presence or absence of disorders. Brain health is critical to healthy aging. Cognitive ability, strong mental health, and high quality of life depend on brain health. The OECD estimates that impaired brain health costs the global economy between $2.5 to $8.5 trillion a year in lost productivity. The bottom line is that the opportunity for economic growth and stability depends partially on healthier brains at the population level. Today, our session, From Data to Decisions, Catalyzing Healthcare Systems Transformation for Timely and Accurate Diagnosis of Alzheimer's Disease, we'll explore how the Davos Alzheimer's Collaborative has worked across the globe to enable primary care and other front lines of care to promote brain health and improve detection of cognitive impairment. My name is Drew Holzapfel, and I have the fortunate role of Chief Operating Officer of the Davos Alzheimer's Collaborative. We're a Swiss foundation and a US 501c3 co-convened by the Global CEO Initiative on Alzheimer's Disease and the World Economic Forum. And welcome to our 5th meeting of the Learning Laboratory. We're excited to be joined by participants from across the globe, representing 40 countries and over 200 organizations. The purpose of today's meeting, to share knowledge, research, and insights from healthcare systems around the world to achieve a comprehensive global strategy for timely diagnosis as a driver of brain health. Specifically, today we'll explore the innovative role of technology in catalyzing healthcare system transformation. And research experts will share their learnings and insights on the emerging care pathways for accurate diagnosis, operational challenges and opportunities in implementing new technologies in real-world settings. We hope you'll walk away from this conversation with a better understanding of what's needed to ensure successful implementation of these technologies and these tools. We're honored today to have Professor Suzuki, a DAC board member, join us. Dr. Suzuki is the former Chief Medical and Global Health Officer of Japan's Ministry of Health, Labor and Welfare, and the former Vice Minister of Health. He's currently the President of the International University of Health and Welfare and a great resource for the Davos Alzheimer's Collaborative. Understanding and promoting brain health on a global scale is not only a matter of delivering healthcare, but it's also a pivotal step towards fostering cognitive resilience. Promoting brain health can mitigate the impact of neurological conditions, including Alzheimer's. And to ensure an equitable access to cognitive potential that exists within every individual, regardless of geographic location. So now we'll start our program, and just a note that we want to hear from you during the course of this program. We want this to be an interactive dialogue, so we hope that you'll use the Q&A function to pose questions for the speakers and have conversations with the other participants. Now I'll turn it over to Phyllis Farrell. She's an advisor to the DAC Healthcare System Preparedness Program, and she'll lead us through our first session today. Phyllis, over to you.
Thanks, Drew. So thrilled to be here. And I'm going to welcome onto camera my dear friend, Paola Barberino from Alzheimer's Disease International. So you can join me, Paola. So I'm calling in from Atlanta, Georgia. Paola, are you in the UK today? Where are you today?
I am. I'm in London, but it is a lovely sunny day for a change.
Oh, good. Okay. So Paola and their partnership with the Davos Alzheimer's Collaborative at Alzheimer's Disease International have been a really critical part of the DAC System Preparedness Initiative. So I'm really excited to start off today's Learning Lab with you. And you and I could just have a little chat here like we would if we were together in a conference, and I wish we were. But one of the things, and most of this group probably knows this, but the first set of flagship programs and grants for the DAC System Preparedness Program were focused on early detection, and specifically early detection of cognitive symptoms. Because we know that if we can catch these symptoms at the earliest time possible, we can do more for the disease, but also for the patients and their families living with this disease. So we had reached out through DAC to ADI because you guys have one of the best member networks around the world, and you helped us basically publish the first RFI for those grants. And maybe not everybody knows this, but we received almost 80 responses from like 25 countries. And a lot of that was because of your members. So we realized that the quality, not just quantity, but the quality of the proposals that were coming in was thanks to your partnership. So I'd like to just start by asking you why you were excited about this partnership. Why did you want to collaborate with DAC system preparedness on early detection? Why was this important for ADI?
Thank you, Phyllis. Yes, I still remember the call that we had. We had a long call whilst I was in a park in London, and we will talk about the substance of that call later, I think. The reason why we were excited is that there are very, very few places around the world that are truly interested in increasing capacity in research in lower and middle income countries. And the substance of the Davos Alzheimer Collaborative was to try and find funding that would cover not only high income country, but also lower income country. And also it was subtler than that, trying to understand the challenges. And of course, you came from the industry side. And for us, it's really interesting to have more industry talking to our members. Our members themselves may not be the right people to carry on research, but they will know local university. Essentially, we know, you and I know, that in the Alzheimer space, there's been very little focus and very little research. Only 1 in 12 studies in comparison to cancer are in Alzheimer research. So you get 12 studies on cancer versus 1 in neurological disorders at large, as we said back in 2018. So for you to really want to put some money and some time in discussing, because this is about learning, it's almost like the clash of two worlds, a world that has not really been given the opportunity to do research locally, and a world that was interested in learning more. This has been a complex project, but we were very excited about the opportunities.
Well, and I love that you brought up low and middle income countries, because obviously making sure we had diversity in the responses was good. One of the things that was really fun to watch as these grantees work together and the flagship sites work together across communities of practice is it wasn't high resource countries always teaching low and middle income countries. In a lot of cases, the low and middle income countries were sharing their learning, and the high resource countries were soaking it in as well. I happened to be at Lausanne a couple of years ago, and the president of the Aga Khan University said, when it comes to Alzheimer's disease, we're all developing nations. And so one of the things that we've really enjoyed is watching these folks interact, which is probably something that you see a lot at ADI across your members. But we got to see it in this system preparedness space as well, and how much shared learning there actually was. I would say the caveat to that is we also learned, and you mentioned this, when you've seen one health system, you've seen one health system. And really, to make change, your members on the ground have to be knowing their local academic institutions, knowing their partners, and really being able to work the change from the bottom up. So one of the things that's coming out of these grants now, and the flagship, which is going to be released by the end of this month, and I'll show a little snapshot of it later, is actually a blueprint, an implementation guide, essentially, for health systems anywhere to walk step by step through how might they do early detection in their primary care settings. What do you see ADI's role moving forward once that blueprint's available? Do you see some partnership opportunities there with your members to make sure that that blueprint is available locally and people are aware of it?
Well, the issues relating to early detection and timely diagnosis are massive. And one of our greatest challenges is to get governments focused on them at this moment in time, in particular, where healthcare system preparedness, as we know, is lacking so massively. So we do promote and we do encourage any initiative that is aimed at creating some interest and provides simpler ways to ascertain the preparedness of systems. So for us, this is yet another tool which comes at a very good time, is timely, and is rooted also in the experiences that you have had in this last couple of years of talking to people. That is the critical thing. So if you had given me a tool like this 2 years ago, I would have said, well, I'm not entirely sure how useful it is, but now you yourself have learned so much by working with people about what you just said. You've seen one healthcare system, you've just seen one healthcare system. And of course, the working with healthcare systems, we learn constantly, and obviously by comparing one with another, also we have opportunities for disseminating best practice. But yes, you know, the local situation, as some of your other speakers will talk about after me, is always very peculiar to that nation, and respect of the individual cultural, but also capacity of each nations are extremely critical. There's no point in us developing a model that is not useful. Models have to be adaptable to the local situation. It's obvious that there is a lot of tools being developed at the moment, so it's important also not to overwhelm people with too many tools. But on this particular area, there hasn't been a lot done.
Yeah, and I think that's one of the reasons DAC leaned on more of an implementation guide blueprint, which is, you know, diagnostic tool agnostic, product agnostic. In a lot of cases, it allows for a lot of variety as it relates to culturally appropriate. And when we say culturally appropriate, we don't just mean it translates into the language. It has to translate into the workflow, right? And the workflow is different. So we learned a lot from the ADI members in that. Now, I want to pick up a thread that you just mentioned, because I think it's really important. And this is the idea of timely versus early. This is some language, and specifically to cognitive symptoms, that is complicating in the field right now. Sometimes people think early means early onset, or early means pre-symptomatic. So why is this so complicated in the field right now, this nomenclature around timely versus early, and how are you guys thinking about it with your communications?
So this is something that Phyllis and I discussed very early on in this discussion about Davos Alzheimer Collaborative, because at the time, I think it's fair to say, Phyllis, it wasn't really, you hadn't really embraced this problem. So for us, it's always been about timely diagnosis. To say early is always confusing, because people think that they have to know about something very early on, when actually it may not be necessary or appropriate, or it may even clog healthcare systems with people that are looking for answers when actually answers are needed, and preventing access to people that need answers when those answers are needed. It's a complex issue because it goes back also to primary care. So you want a timely diagnosis, because the more timely a diagnosis, the more likely you are of the person that knows that they have Alzheimer, they have some kind of dementia, they know what can be done after. So it's not about leaving an individual, a family in the dark. It's about providing information. So when you and I were talking originally of the clinical trials, my question to you was, okay, so you're getting people to do clinical trials, so they will know that they have a diagnosis of dementia. But the most important thing is that you can actually build capacity in those countries to give post-diagnostic support, because without post-diagnostic support, that diagnosis could be detrimental to the family well-being, mental health. It could create a huge amount of problems. So I think you and I have progressed in this conversation, and I know that you have had this conversation many times with members, and it's there that the cultural issue really also strikes, because to an extent, the level of information required depends on the awareness in that country, and also the level of stigma. The things really go hand in hand. So a family that has never really considered dementia a big issue, has never really considered it at all, can be completely thrown off course by a diagnosis that is not supported by a care pathway, or at least an understanding of what could happen afterwards. And this is what really the World Alzheimer Report 2022 and 2021 were: diagnosis and post-diagnostic support.
I think that was a very specific learning. You're right. I'm kind of letting people into our little coffee chats. And, you know, one of the things that we had done when we put that RFI out, thanks to your encouragement, was making sure that, even though the project was on early detection, the leader of the project had thought about what they were going to do around post-diagnostic support. But I want to take one more step in now to the diagnosis cascade. So obviously there's timely detection of cognitive symptoms, but then there's this idea of accurate diagnosis. So these cognitive symptoms, obviously, they could be caused by a lot of things, which is one of the reasons we want to catch them early, because some of them may be reversible causes. But that next step around accurate diagnosis, there's some thought that that really only needs to happen in a country where a disease-modifying therapy is happening. And I know that you've been spending a lot of time at ADI to capture the rates of diagnosis around the world. And I don't know if you want to talk a little bit about the ADI perspective on how important an accurate diagnosis is generally, even in places where these disease-modifying therapies aren't available.
Yes, there are a number of issues that you're raising here. I've got a slide that you may be able to pass quickly in the screen, just for people to remember the numbers. So in these various reports, we realize that 75% of people with dementia are not diagnosed globally. And if you think that there are 55 million people living with dementia now, that equates to about 41 million, which is huge. And that is high, even in high-income country, about 60%, whilst in low-income country, it gets up to 90%. But as you touch, so we're talking of timely diagnosis or what have you, but the reality is that the vast majority of people don't get diagnosed. And you may recall that in the World Alzheimer Report 2019, we found out that 62% of healthcare professionals, so doctors and nurses, felt that thought that Alzheimer and dementia were not part of a disease or a condition, they were part of normal aging. So that's the scale of the problem we have. The other problem we have is exemplified in this slide. Postmortem research suggests that up to 30% of people may be misdiagnosed. And you all know that there are all kinds of spectrum of issues around this. I think we can put the slides away. So we essentially know still so little, and this is working against us. And I know that later in this meeting, you will speak with people that are working on blood biomarker and biomarkers in general to detect and diagnose better and more accurately. We desperately need this because these rates of misdiagnosis don't help us. However, we do know, because we've asked the people all over the world, we did this big survey in 2019 that included 70,000 people. By and large, the general population wants to know. They want to know whether they have something or not. And it's a human right of everybody to know whether you have something or not. So the diagnosis issue is still extraordinarily important. But the education issue is also terribly important, because then if you go to a doctor that really doesn't sympathize with your symptoms, doesn't understand or recognize the symptomatology, or in some cases, as some GP friends have told me in some high-income country, if you've got nothing to offer, they may prefer to just presume that to just give this possible chance that this is part of normal aging. It's just simpler for them than really tackle the truth.
Yeah, I mean, I think we think about this in cancer all the time, right? Which is, you're always better to catch cancer at stage 1 than you are at stage 4. It just gives you so many more degrees of freedom. And I think that's the same case in cognitive impairment. Having lived with this in my own family, being able to get the support and the care and some of the answers. You know, it's interesting. One of our grant beneficiaries did this in pharmacies. And we had thought about early detection in pharmacies more as a way to open the front end of the funnel with an allied health professional. What we didn't realize and we didn't think about was how those skills of those pharmacies were even able to identify medications that could have been either causing the cognitive impairment or worsening the cognitive impairment. And so they actually brought this skill set in, and doctors had a great appreciation because they were able to not just do the early detection, but also do the medication review. And I think those are some critical things that we have to think about for families. I've only got a couple more minutes with you. You and I could talk about this forever, but I would be really remiss if we didn't pull on this idea of post-diagnostic care and support. So we're advocating for timely detection of cognitive impairment. We're advocating for accurate diagnosis. because some of these causes of cognitive impairment might be reversible or may have other important things that the family and the physician needs to know. But you still need to have the post-diagnostic care and support. So who do you think is best situated to lead that driving forward? And you've got this platform, what would be your call to action in this space around research and investment in post-diagnostic care and support?
We do need more investment. I mean, I'm talking right now with two governments that are actually pulling back from research, from investment in care and support. And that is because of what's happening in our world right now. You know, in a way, it's very exciting. We are looking at possible disease-modifying therapies. But the costs of these are very, very high. As you know, there's been some really interesting work published by Anders Vimo about, for example, in Sweden, when we consider the whole eligible population, a list price for an AD medication would consume 80% of the total budget. Some studies have been done broadly also by Anders and his team on Europe. So there is a lot of concern, and governments in a way are reluctant now to invest anywhere in a way. And this is a really, really big issue. So we need to persuade together of the importance of investing in both. In a way, the two things have to come up together. Also because these therapies are not going to be available to everybody. There are people that are going to be sorely disappointed, and that could also impact negatively on the availability and the accessibility of therapy. So we want people to understand that if a therapy is not available for an individual, there's going to be psychosocial intervention, there's going to be rehabilitation program, there's going to be information on how to modify a house to let someone live independently for longer. So really, scientists and care scientists need to work together now more than ever, because otherwise we risk to have a very imperfect world for the people that are living with dementia and for their families. You've had it in your family. You've seen the chaos that this can wreck into a family, and we know that what's coming is not going to be perfect for everyone. So we need to make sure that there is no disappointment. We come into this with our eyes open, making a very clear point about what is going to work, what's going not to work, and how can we fill those gaps.
Totally agree. And I'm going to make this a very explicit ask, which is we know that the private sector does not invest in some of that care research as much as they do in some of the other areas of research. In fact, Dr. Nicole Fowler is actually on this call a little bit later, and that's a central area of her research. I think we need to ask anybody viewing this webinar, either now or in recording later, to think through where are the partnerships that we may have, whether that be in philanthropy, in foundations, in governments. You're going to hear from Professor Suzuki later about Japan, that we really need some of those organizations to step up into this post-diagnostic care and support research, because it is so critical and it works. So right before I turn over, I'm going to ask Lisa to pull up one last slide, because I've referred to it a couple times, and that is the DAC blueprint, the DAC system preparedness blueprint. It's just a picture of it so you guys can see. This is the implementation guide. It is product agnostic, it is tool agnostic, and it will be web enabled and open access for anyone around the world, available by the end of this month. You'll hear a little bit more about it later in the webinar, but we want to make sure that people know that it is here. It is a click-through implementation guide of how you might be able to do this in your country. And we're really excited about it, and we're hopeful that people will use it and give us feedback, because we're adding resources into it so that we're all not starting from a blank sheet of paper. So thanks, Alyssa. Paola, I wish we were together so we could have a toast and a hug. I can't thank you enough for your longstanding partnership, friendship, collaboration, and I'm just so excited of what we're going to keep working on together.
Thank you very much, Phyllis, and good luck with the rest of the meeting. I'm going to type a few of the answers in the chat line as well.
Oh, that would be great. Yeah, stick with us, because we'll probably hear more throughout. Ciao, my friend.
Well,
so with this, I'm going to transition over to Jeremy Abbott, the publisher of Scientific American. I'm very excited about the fireside that he is going to host now. And dear friend Jeremy, it's all yours.
Thank you so much, Phyllis. Thank you to DAC for organizing this amazing forum. Thank you to our global audiences. I'm thrilled to be here, and I'm thrilled to be having a discussion with two amazing luminaries to share their perspective on this global moment. I am thrilled to be with George Vredenberg, founding chairman of the Davos Alzheimer's Collaborative. Great to see you again, George.
See you, Jeremy.
We are also thrilled to have Professor Yasuhiro Suzuki, former Vice Minister for Health, Chief Medical Officer, and Global Health Officer of Japan's Ministry of Health, Labor, and Welfare, and now member of the board of Davos Alzheimer's Collaborative. So thrilled to have you, Professor Suzuki. And thanks for joining. It is definitely a global meeting. I am thrilled to seize the moment, as I've heard George say in the past. And Professor Suzuki, I'd like to start with you. When you think about what needs to happen around the world, and we've talked about, we just heard a little bit about, you see one health system, you've seen one, but we have to work toward harmonization in some ways. But I'd love to just widen the lens on this conversation for one moment. What are the key factors driving this moment right now in Alzheimer's, and particularly the imperative of early diagnosis, early detection? And then what do you see as the broad pathway that governments have to take to enable a better harmonization of these healthcare systems?
Thank you. I was trained as a neurologist. My first assignment at the ministry was the policy on dementia. And my academic doctoral thesis paper was on dementia. So dementia is my life work.
Wow.
Today, I would like to convey three key messages surrounding the early detection. First is the two-tier approach, which is the biomedical approach to dementia and social behavioral approach to dementia. We talked a lot about the biomedical approach, which is the early scientific detection by diagnostics and early intervention by medication. And early detection is very important for biomedical approach, of course. But at the same time, we do need a social behavioral approach to dementia. Because for human being, mental function comprises of two functions. One is the cognitive function. The other is the emotional function. In case of dementia, cognitive function is going to be impaired, but the emotional function is going to be retained. So if the cognitive function is going to be impaired, you are going to make mistakes about your judgment and your statement. But if you're going to be pointed out very aggressively about your mistakes, you'll be very upset. And this upsetting is leading to the behavioral and psychosocial symptoms of dementia, such as delusion or polymania, which makes the care very difficult. So early detection is very important also for this type of social behavioral approach, because you can let them know, the caretakers or family members know what not to do to the patients with dementia in order to prevent the psychosocial syndrome of dementia. Second is the detection of dementia has to be made at the primary care level, because the numbers of the potential patients are enormous. But you need to have the specialized core hospital in order to make the differential diagnosis. So you need to have a reference system between the two. But in many cases, these primary care physicians are not well prepared for the detection of the early detection of dementia. So you need to have a very better tool for the early detection. Yeah. And third, we have to talk about the treatable or reversible so-called dementia. It's a cognitive impairment, but can be treated because these impairments are being caused by depression, chronic subdural hematoma, or normal pressure hydrocephalus that can be treated by medication or surgical intervention. In order to do that, you have to early detect those symptoms and try to figure out the solution to these dimensions. So I think these are the three key messages penetrating across in terms of the early detection of dementia. Thank you.
That framework absolutely is a great way to think about this, and just underscores the importance of early detection. I'd like to throw it over to you, George, for a bit of an opening. You know, we've talked a bit about this global moment and the world aging and the drivers of this imperative in different parts of the globe. And from where you sit, and again, your organization is doing amazing work for such a nascent organization. What are the key factors driving this? And again, what does it mean for health system preparedness? We just came out of a crucible of a global health crisis that I think opened the world's eyes to the diversity of healthcare systems and the importance of getting this right at a community and local level.
Well, thank you, Jeremy, and thank you, Professor Suzuki, Dr. Suzuki, for joining our board and to offer an insight from your perspective as a neurologist. I am not a neurologist. I'm not a doctor. I'm a lawyer with 3 generations of my family lost it to Alzheimer's. So I am in this as a sort of a patient advocate. But what I see as the global moment is the increasing recognition. The numbers of people affected by this disease is enormous and growing. The estimates are something north of 50 million people with dementia. But that hides the fact that now that we know that the disease course starts 20 years before that period, there are over 400 million people with the disease. Only 50 million have been diagnosed. And so when you look at the extent of this disease in largely large middle-income countries and increasingly in low-income countries, this problem is a global problem. It is not going to be solved by one country. It's not going to be solved by one company. It's not going to be solved by one academic institution. It is imperative to come together to solve a global problem. So scientifically, we've now had in the United States and in Japan the approval and payment and coverage for a disease-modifying drug, meaningful to patients, but high cost and with it's neither a cure nor a prevention of the disease. So we're going to short-term need to reduce the costs of that drug by reducing the costs of being diagnosed and reduce the costs of getting on the drug. And so that work is going on. But we're also learning, as Professor Suzuki has outlined, that in fact we can, by interventions in midlife, actually reduce the risk of dementia by potentially up to 40%. And so the earlier we can identify the risks for dementia, the earlier we can identify and detect cognitive impairment, the more likely it is that we will have medical or non-pharmacological interventions that will reduce this disease at a global level. So we need to reduce costs, and we need to engage primary care because for the reasons Dr. Suzuki outlined. And that means in the political world, in the global health world, primary care investment is critical and that we need to do that. Now, primary care in our language is health system preparedness. How is it that we can begin to educate, inform, and help implement at the primary care level brain health interventions, whether they be comorbidity management in midlife, lifestyle changes starting in midlife, or as we begin to get combinations of antihypertensives and anti-diabetic medicines that are generic in quality, so low cost, coupled with low-cost interventions, coupled with lifestyle changes. I think the earlier we'll be able to get at this disease at scale and at low cost.
As we heard earlier, an accurate diagnosis can be seen as a human right, right? The pursuit of health, the pursuit of healthiness, and that, you know, the accurate diagnosis leads to what is the treatment pathway. And as noted, you know, by Professor Suzuki, there could be different things driving this. What are some steps that, you know, governments can take to make sure that there's a healthcare system infrastructure in place that could, you know, make sure every part of that chain is as supported as possible as we get to better diagnosis and certainly, you know, as care models evolve?
I'm sorry. Go ahead.
No, go ahead, George.
Absolutely. Question for both of you. Absolutely.
Go ahead, Dr. Suzuki.
Okay. I have worked for the government for 36 years, and I have been communicating with the Prime Minister's office very frequently. And in order to push the agenda of the early detection and primary care model to the national level, we need a very strong political leadership and initiative from the top, the Prime Minister's office or President's office, because it's not only healthcare. It's about the commerce, it's about transportation, it's about the land and everything. So all parts of the government have to be involved. So that's why we need to have the very top-down, strong political initiative to push forward this very important agenda. That's what I think.
Because of the diversity of infrastructure that's required in all of these care scenarios. And George, I'll you know, I know you had some comments on this topic.
Well, I agree 100% with Professor Suzuki. We need top-down leadership. We have had extraordinary increases in investment in basic research in the United States. It has not been tracked in the rest of the world. And so my focus is increasingly on trying to get governments around the world to link their efforts, to understand what research needs to be conducted and to share that research globally. Because I do believe that there's an enormous amount to learn about research in low and middle income countries, where we have different genetic, different environmental exposures and the like, which will teach us a great deal about the underlying causes of this disease and potentially the underlying solutions. But we also offer to the world a global marketplace for pharmaceutical and biotech firms to say, basically, if we can provide a global infrastructure for the early detection of the disease or risks of the disease, we can offer a global marketplace that in fact will stimulate much greater private investment as well as government investment. So political leadership, yes, but it has to work in conjunction with what that leadership will produce both in country, but around the world. This learning lab has taught us that we have a lot to learn from each other as we think about what the primary care infrastructure ought to be in order to implement either pharmacological or non-pharmacological interventions. Same thing should be happening at the government level. G7, G20, yes, but also low and middle income country involvement. So collaboration across governments and with industry and with academics and with patients, I think is critical.
I'm seeing a snowballing effect. You see progress in one area, you see an ability for not just investment, but as you note, pharma, biotech, an entrepreneurial environment to incentivize their efforts. And I think you're seeing, I mean, just from my probably even unscientific look at this space is heating up because I think industry knows there's an opportunity here. Patient advocacy groups are becoming more vocal in what they need. And I'd love to, just because DAC is such a unique group, where do you see the efforts being focused on the next 5-10 years? What excites both of you about the future? If you could look at if all goes to plan and DAC's mission starts to gel globally, where do you see successes? Obviously, there's going to be numeric successes, right? Statistics, early interventions. What's your ideal view of the world in 5 and 10 years in this space if this mission is realized, and I know it will be. Professor Suzuki, you want to opine on that?
I think the beauty of DAC and the global initiative is that you can avoid overlaps and duplication of the efforts happening everywhere in the world. And you can share best practices, even in research or the psychosocial interventions. Those good practices can be shared. So that will be leading to the very efficient and effective global approach. I think that's the beauty of this type of global initiative. And to me, my dream is within 5-10 years that we are going to have the 100% cure of the Alzheimer's disease. Because currently, injection treatment, you can delay the onset of the symptoms about 27% of the patient for 18 months. That's a very good advancement, but not perfect. Yeah. So within 5 and 10 years, if we're going to have this type of perfect solution to dementia, that would change the whole picture. That's what I think.
But we'll be, incremental innovation has its place. I mean, we would love. There are very few overnight successes in the world of medicine. I'm thinking back to maybe, the transformation of diabetes 100 years ago from something that was a death sentence to something that's manageable. The incremental advancements we were able to make in HIV and AIDS, looking at some of the other diseases that we've had progress with, but then looking at how the landscape was transformed because policymakers, patients got together and said, we have to solve this. George, I'll throw it over to you. Is there a lesson we can learn as you look to the future, as you look at what DAC can do as a catalyst for global conversations? What's your vision for the power of those collaborations? And then, yes, as Professor Suzuki noted, we'd love to see transformative therapeutics, but it's going to take this whole arsenal, this whole portfolio. Where do you see the future of it? Where do you see the timelines? I know it's hard to predict, but it's an exciting conversation to have.
Well, I'm going to pick up on both of some of Dr. Suzuki's themes, but put it slightly differently. I would, over the course of the next few years, I am hopeful that we will integrate our thinking about the prevention of this disease starting in midlife in a variety of behavioral ways and managing comorbidities that we know create the risk of future dementia. Integrate that thinking with primary care investments around the world, coupled with vaccines for Alzheimer's. We have now a work group of 8 companies and 4 regulators sitting in the same room talking about how to get to a vaccine and secondary prevention by the end of the decade. So the question is, how do we accelerate those processes through collaborative work? And the governments are sitting down with industry to say, this is what we regulators think we will need in order to approve the use of a vaccine. And companies are sitting there listening to that and understanding how they may shape their strategies in order to meet the regulatory requirements and eventually the payment requirements for vaccines. So in the next 5 to 10 years, an integration of our thinking about prevention through risk reduction and comorbidity management, and a vaccine on market, hopefully by the end of the decade.
Just the mere thought of that gives many people in this space chills, right? I mean, and when I think about scientific innovation that at one point was almost mocked, early days of immunotherapy, tell the 15 experimental patients that were transformed, who had a death sentence that lived, that are still alive today after 15 years. So this kind of big thinking excites so many people, and I feel, again, as someone who works in the world of science media, the public's understanding and appreciation of where this could lead, and keeping them excited about this, not just the public, but governments, et cetera. So I know we only have a few minutes left. I'd love to close with right now on the immediate landscape. What do you feel, and I'll start with you, Professor Suzuki, what do you feel is the biggest challenge we could tackle right now to make some of these things happen and to realize the important mission of DAC?
I think the most biggest obstacle before us is the tools for early detection. We do have the amyloid PET, and we do have the lumbar puncture, but those tools are somehow invasive and costly. Of course, we do have some biomarkers in blood, but there's the issue of accuracy. So what we need, perhaps within 5 years, is a more accurate, less invasive, less costly diagnostic tools. If we're going to have it, we can do both the biomedical intervention and social behavioral intervention.
That's great focus. George, what do you think? Biggest challenge right now you want to tackle?
Oh, well, we have to actually, this is going to sound obnoxious. We have to teach our health system that the brain is part of the body and the body is part of the brain. And that we have to get not just neurologists, but primary care physicians to understand the relationship between the brain and the body and to deal with them both. That is exactly what Dr. Suzuki said. We need to lower the cost of detecting this disease as a cognitive issue and as a disease issue. So blood-based biomarkers, digital cognitive assessments, subcutaneous, that is shots rather than infusions. So lowering the cost of getting primary care involved in the process of detecting and then diagnosing this disease is going to be critical in the short term. And I think we have to keep in mind that regulatory actions and payer actions actually can stimulate innovation. We have seen companies come back into this space that had pulled out of it as a result of the FDA action in the United States and now PMD action in Japan. Why? Because they see that there is a regulatory path to the marketplace. And so we recognize that the government actions in this space and have a stimulative effect on the innovation pipeline that we've seen with HIV/AIDS, that we've seen with cancer. There's an apocryphal, to your point, there's an apocryphal conversation that occurred with Dr. Sabin back in the day, who was told, we're going to have to create enormous numbers of iron lung hospitals and a huge leg brace manufacturing industry to cope with the growing prevalence of polio. And he said, no, we need a cure. To Dr. Suzuki's point, we need a cure. And so we're going at the cure through a vaccine. That's going to require combinations of regulatory actions, payer actions, government investment, and industry work together with patients driving that process quickly as we can.
Well, that's a great way to frame it. You know, thinking big, thinking global, but acting local is going to obviously be the key to this. Gentlemen, we're out of time, but this was an amazing discussion. I know we want to move things along on this webinar. I thank you for the perspective. Again, I thank DAC for the vision. Very soon, there'll be some announcements around a collaboration that Scientific American is actually pursuing with DAC. And we hope, again, that collaboration yields more public interest in this and helping to that effect of snowballing, of excitement, begetting more excitement. So with that, I'm going to introduce our next session. A gentleman I know well, Tim McLeod, is going to be, he's Director, Healthcare System Preparedness at the Davos Alzheimer's Collaborative. He will be facilitating our next discussion on Innovation Unleashed, bridging the gap with real-world applications of Alzheimer's accurate diagnosis innovations. Tim, great to see you, and I'm thrilled to witness the next session here at this webinar.
Thanks so much, Jeremy, and thanks so much for an engaging panel for George and Dr. Suzuki. So as Jeremy mentioned, we're going to move forward and talk more about system preparedness in the accurate diagnosis space and sort of bridging the real world application of novel tools. And so I'm thrilled to have the opportunity to speak to you this morning and introduce our panelists in a few moments. So, against a backdrop of really rapid innovation and sort of the pace of change over the last couple of years with diagnostics, this is a really exciting time to be thinking about this issue. And so this morning, I want to do three things. So I want to give you a background on some of our DAC SP programs, so where we've been and where we're going. And in that vein, I'll introduce you to what we're thinking about and doing on accurate diagnosis over the next year. And then I'd love to introduce my expert panel, who are going to bring insights on accurate diagnosis from the point of view of the diagnostic pathway, some of the operational challenges and enablers required to deliver that pathway, clinician responses to it, and education. And so jumping right into our past DAC SP work, if we could go. So this is our system preparedness framework. So many of you who have joined these calls in the past would have seen this a number of times. So this framework forms our North Star. So we put it together with a multi-sectoral working group in 2020 when we started our programming. And on the left, you sort of see public health and health promotion. In the middle, you see the beginning of formalized care pathways with screening and early detection. And to the right, you see post-diagnostic care planning. And so our starting place was with early detection. And so we ran a flagship program and a grant program in 19 sites in 12 countries. And so the focus of that study was really understanding how do we get more cognitive assessment in primary or non-specialist care. And that program utilized blood-based biomarkers and DCAs, as well as other tools. And so we're really excited to be moving forward and building on that study with accurate diagnosis, where we're going to incorporate CSF and PET into the care pathway in new sites. And so to give you sort of a flavor of the type of research that we do, we use implementation science. And so on the next slide, I think to make a complicated field quite simple, we can think about the empirical evidence we have of the uptake of clinical innovations. And, it's well documented that even when we have a solid evidence base of novel health innovation, we still see this persistent adoption gap of 17 to 20 years to get these innovations into routine clinical practice. And so a great analogy here is, when we're discovering novel tools, we can think of those as really fast trains. And so we also need to make sure that health systems have good quality tracks that are capable of running these trains for patients and their families to have access to them. And so the type of implementation science studies we run really seek to understand what's working well and less well with the tracks. And then what are we able to do given that? And so we create really tangible things like blueprints that help to guide implementation and translate learnings. And so on the next slide, as we move into this accurate diagnosis program in 2024, so we are just finishing operational planning this quarter and are looking to launch sort of in the first quarter of next year. Broadly, we're going to run this in 8 sites, so probably half in the US, half in a combination of Europe and Japan. And we're going to be using specialty cares with satellite networks with the capabilities to deliver key components of the model, namely cognitive assessments, blood, and CSF or PET, depending on jurisdiction. And so at a high level, the goal here is to really understand what are the operational barriers and facilitators to health systems absorbing blood and CSF or PET. And as part of that, the resource use we might see by putting blood in different places in the care pathway. And so because our studies are not seeking to validate tools and we want to make sure that they're sustainable and scalable, we're using tools that are either commercially available or are very late in their diagnostic pathway. So we look forward to giving you more updates about this program over the next year. We're really excited to be moving forward with it. and to sort of give you a flavor of what we're going to be working on and thinking about. We've brought together an expert panel today who all have different expertise on accurate diagnosis and some of the challenges involved there. So with that, I would invite my panelists to turn their cameras on. And to start, I just would like to invite the group to introduce themselves. So maybe just give us a minute or two on where you're coming from and the background and research that you're thinking about right now. So Chi, maybe let's start with you.
Yeah, sure. And thank you very much, team, for convening this. It's so great to be here. I mean, the conversations have already been really excellent so far. My name is Chi Udemomo, and I'm based across Wake Forest University in the US and Aga Khan University in Kenya, and I'm saying hello, or actually I should say speak Swahili perhaps. So I'm currently in Kenya here, so do bear with me in case there's any network disruptions, because I'm also based at Aga Khan University in Nairobi. So my background is in neuroscience, and I work in the space of dementia risk reduction, pathology, and risk detection, but also prediction, looking at biomechanistic pathways underlying ADRD mechanisms in diverse populations. So that's really the lens at which I work in the space of ADRD, and I'm really interested in trying, and I loved what Paula was talking about with regards to timely diagnosis, and I'm hoping to talk today about the work that we've been doing with the global COI on blood-based biomarkers and its implementation in clinical practice, but also how we can really allow for accessibility.
Great. Thank you so much for joining us, Chi. I appreciate it. Charlotte, why don't we go over to you next?
Thank you very much, Tim. Good afternoon or good morning or good night, wherever you are. Is Charlotte Teunissen. I'm professor in neurochemistry in Amsterdam University Medical Centers in Amsterdam, the Netherlands. So the goal of my research is to improve patient care of neurological patients using body fluid biomarkers. So as you can imagine, we worked in the past a lot on CSF biomarker, but nowadays we're focusing a lot on plasma biomarkers for Alzheimer's disease. So dementia is our main focus. And we're running several programs about implementation of the plasma biomarkers. For example, we're running a real-world implementation prognostic study currently in our specialty center, the Amsterdam Dementia Center. And we want to go further to the general neurology practices that's also starting up. And ultimately, we're exploring how we can implement the use to improve patient care in primary care. So that's it for now, I think, in a nutshell. Thank you, Tim.
Great. Thanks again for joining us this evening for you, or this afternoon. Ara, why don't we go to you next?
Oh, thank you. Thank you, Tim. Hi, my name is Ara Khachaturian. I'm Executive Vice President of the Campaign to Prevent Alzheimer's Disease. Some of you may remember me when I'm also the founding editor of Alzheimer's and Dementia. I was there for 18 years. I have a strong interest in epidemiology, biostatistics, and all things public health. I'm also currently affiliated with the UNLV Supercomputing Center. And also I'm leading something called the Brainwatch Coalition, which is very much interested in supporting the mission of Davos, the COI initiatives, and many other global Alzheimer's efforts, trying to promote brain health in a more timely fashion. So I'm looking forward to this discussion. Thank you.
Thanks, Ara. And Nicole, over to you.
Everybody, my name is Nicole Fowler. I'm at Indiana University School of Medicine, also with the Indiana University Center for Aging Research. And I'm a health services researcher and decision scientist who really for the past 15 years have been trying to establish the evidence base for the risks and benefits of early detection of cognitive impairment, mainly in primary care and home and community-based settings. As you can imagine, the interest in my work has gotten bigger over the past few years now that we've identified different ways to do detection other than paper pencil tests. And I think I oftentimes serve as a bridge between primary care and the subspecialties, being somebody who thinks about implementation science and really using sort of Tim's analogy, how to improve that journey of the train. And so obviously, you know, we are excited that there's opportunities to think about how to potentially slow the train, but my job is to think about how primary care patients can have the best journey possible, living with Alzheimer's disease and dementia.
Great, thanks, Nicole. So I'm super excited for this panel. There's a great sort of wealth of experience here in different corners. So I think, you know, today it might be interesting to talk about what a near-term care diagnostic pathway might look like, and then to dive into some of the operational issues that some of our panelists have seen in their own research, as well as what sort of good looks like for education for clinicians. So to that end, Chi, why don't we start with you? I know with the CEOI blood-based biomarker work group, you've been thinking a lot about that with the group and that sort of near-term pathway. So why don't I turn it over to you to sort of tell the group about the outline of the work that you've been doing?
Yeah, sure, Tim. I'd be absolutely delighted to. And I think I should just frame this by saying one of the most important considerations, I think, for implementation work is, you know, for the activity to have minimal logistical barriers. And I think that was, you know, how we thought through the work that we're doing in the work group that the Global COI convened, aimed at providing recommendations on how blood-based biomarkers could be adopted in real-world settings. This was primarily in the US context. I've been really privileged to co-lead this work group of experts in ADRD field alongside Professor Michelle Mielke, and through weekly forums and deliberations, some a little too loud, with the core team and larger work group members, our group really tried to determine actionable recommendations on how we can leverage blood biomarkers in both primary and secondary care, really keeping in mind that mantra, it has to be simple and effective, right? But then there's obviously, we're all aware of, you know, disparate clinical care systems, but also the complexity of dementia etiology and diagnosis. And I've just been reading some questions in the chat. I also work in Africa. There was a comment. So in low resource settings, you need to really think about difficulties with the diagnostic pathway. So I also was looking through those lenses in the determining of these recommendations. But we had to make some critical assumptions, I think, to really focus the work group's recommendations. The main one was that the work group would focus on the use and implementation of blood biomarkers among patients who present with cognitive symptoms. So we were not providing recommendations for people who are cognitively unimpaired, but I do want to consider, of course, that that's something that may be warranted in the future. But for the purpose of this particular work stream, we're really thinking about people already showing who are currently symptomatic. There were some reasons why we thought that, obviously, with disease-modifying therapies only being approved for use amongst individuals who already present with cognitive impairment, alongside detectable amyloid pathology, but also the prognostic value of the fact that the prognostic value of blood biomarkers, I guess, it's testing in asymptomatic populations. It's not really, I mean, it's beginning to be well described. I know that there's work, especially you know, from the US, but also the Europe and Europe on this work, but we still need some more evidence for it to be applied from a clinical or public health perspective. And I'm just thinking again to Paula's comment about Phyllis's conversation regarding early versus timely diagnosis. So I'm glad that we really stuck to our guns around the symptomatic population that we're interested in. But there are also, of course, some several ethical aspects that need to be considered for diagnosing AD pathology in cognitively unimpaired individuals. I'm sure Ara will probably be speaking to that because he does lead the work stream where they really talk through, you know, the ethics of potential diagnosing asymptomatic individuals, some of the legalities that might come up in such use. So as a foundation for these recommendations, we described some minimum acceptable criteria for the anticipated use of blood biomarker test, and just focusing on a near future scenario. I should say that it's current in some parts of Europe. I know that Charlotte is here, and there's also teams like in Sweden where it's already being used in clinical care. But we expect, at least from the US standpoint, that one use of blood biomarkers in the very, very near future. I think it is actually being used in some parts of the US because it is available. For instance, I won't name the labs, but it is available in the US as well. But we do think that it's used as a triaging tool, adopting kind of like a rule-out concept where a negative test would identify individuals who are unlikely to have detectable brain amyloid pathology, will allow health practitioners then to further investigate non-AD related causes of cognitive impairment, whereas a positive blood biomarker test could be used for triaging people who, triaging would be individuals who we think may be at high risk for brain amyloidosis, and who may need subsequent investigation to confirm the presence of amyloid pathology. So I want to just talk through one of the core outputs of our work group. Thank you very much for putting up the slide. And so I want to present, the definition and how we defined a classical patient pathway. Bear in mind, this was really thought through by people from primary care. We had people in the work group from specialty settings, so neurologists, geriatricians. And so I think we really tried very hard to capture as effectively as possible what a typical patient diagnostic pathway could look like, especially with regards to the triaging pathway from initial assessment settings all the way through to secondary or more specialized care. So I'm going to start from a patient coming into clinic. I have people's faces up and it's impairing my visibility, but so patient comes into clinic. Here we're kind of leveraging also some of DAC's innovations around brain health facilitators. And so initially we're thinking primary care physician, but we've changed this to healthcare physicians, healthcare practitioners. And this can include nurse practitioners, physician assistants, people who are trained brain health navigators, or primary care physicians, if that's what's available. So they come in, collect, so they see the patient, collect the medical history, performs a brief physical exam, depending on their training and level of clinical training. Assess the family history. We know that this is usually brief with the initial phase, and then assess the clinical need for additional evaluations, obviously discussing this with the patient. If there is a positive signal, we expect initial workup that could involve some brief cognitive screening, blood works for treatable causes of dementia. And I should also state here that there are two pathways here. So we expect that some healthcare practitioners will feel comfortable to be able to order an ADRD, an AD blood biomarker test, and depending on settings, whether it's rural or urban area, and availability of neuroimaging, might at that point also request a brain neuroimaging scan. Here, if with regards to the results of the blood test, if there's continued suspicion of AD, so positive signals, we expect them, so that would be an effective triage where the healthcare practitioner then triages to more specialist settings, and then the specialist, so neurologist, geriatrician, performs the additional workup, including more detailed history, examination, cognitive assessments, and may or may not require at this point a triaging blood biomarker test. They may interpret the ones from the primary health setting, and if the results indicate likely AD symptoms, we expect that a confirmatory CSF or PET will then be required. We've also tried to think through different scenarios where which will lead to the determination of DMT eligibility. So some considerations will include this, determining comorbidities, thinking through genetic risk as well, whether or not there are anticoagulants. All of this will need to be considered. But if you look at the pathway, we've made sure in our vignettes we have very clear indicators of likelihood of progressing to a no, which would then require further evaluation for non-AD causes of the cognitive impairment. We thought through a lot of challenges and we have a manuscript coming out, and this could include results interpretation, for instance, given the different stakeholders within the pathway. And I know that Ara will probably be discussing his work on this, and both Charlotte and Nicole will talk through how they've actually operationalized this in different contexts. And DAC is obviously supporting the crucial need for more real-world evidence to really streamline incorporation of blood biomarkers within the diagnostic workup. But I do want to encourage us also to contemplate all of the opportunities and promise of blood biomarkers for AD diagnostics. Coming from an LMIC context as well, I see its applicability within potentially an integrated clinical care framework, and we're actually trying to look into this with some of the DAC team here in Kenya, and I'd be delighted to speak on this further, as it's something that I've really been thinking through. Thanks.
Thanks so much, Chi. I know from spending a lot of time with our sites in the field over the last few years, there's a ton of complexity, and so actually concretizing it and providing an order of operations is super helpful. Nicole, you've spent a lot of time thinking about this at IU Health, and have spent, as you said, a lot of effort both on implementation science and sort of connecting different functions in the clinical pathway. What are some of the opportunities that you see and sort of learnings that health systems thinking about implementing this might pull forward based on your experience?
Yeah, I think that, somebody I think mentioned it earlier today, which was you've seen one health system and you've seen one health system. And there is some truth to that. And although I think it shouldn't, hinder us from thinking about care pathways. I think, a couple of things that we learned from our flagship experience was first, really being able to have, the sites be able to assess what their sort of own demand is for this, right? And so the reason I bring that up is that we've learned from other studies that, sort of forcing, systems to do something oftentimes doesn't sort of produce the right outcome. So I think one of the things we learned was really being able to give the sites, in particular in our setting, the clinic, some flexibility to determine which workflows worked best for them, when they wanted to include the ask for blood-based biomarkers, when they wanted to maybe assess symptoms prior to administering the digital cognitive assessment. So I think that was sort of one learning that really stuck with us, that was sort of what made it successful, was being able to have that flexibility. I think the other piece, when we talk about workflows, is making sure that we're integrating this information into what primary care providers use as their workflow tools, which is often the electronic medical record. And, I think that was sort of one of the things that we learned that we weren't able to solve, but certainly identified it as a barrier, that being able to have built-in information into their electronic medical record that prompted them, that pulled results in a way that they actually saw it in real time when the patient was in front of them, or at least was able to establish a workflow of when they would bring patients back to talk about this if they did actually screen positive. And then I think the third piece is really having the resources in place for them to think through, what do I do with this information, right? I mean, I think as providers, we want to solve problems, we want to help people. And so if we don't think that there's a decision that we have that's going to result in a solution to help that patient, it might be easy for us to not think about it. So being able to have a resource available in the system for providers to, one, help them talk through, okay, so this patient screened positive, I was really surprised by it. And, what are some of the things? So in our case, we actually implemented a brain health navigator who maybe did a little bit more detective work, for that provider to say, well, you know what? I actually looked at their med list and I talked to them on the phone, and it looks like they actually are taking Tylenol PM before they go to bed. So you didn't know that, but we just found that out, and we think that may be causing some of the issues. So let's talk through that, bring them back, you know, in a few months after they've stopped using that anticholinergic and test them again. And then I think the last piece that we've been really working on, that the DAC initiative has helped us really think through how to tell this story in primary care. And, you know, while we're, like everybody, incredibly excited about the new therapies that we're able to offer, the anti-amyloid therapies, you know, I think it was brought up earlier, maybe by George, that, you know, we know 30 to 40% of initiatives that we can do in the primary care setting can help people's cognitive health. So these are sort of modifiable factors such as diet and exercise and reducing depression and, you know, reducing anticholinergic medicines. So, and we will work with you to do that. If you are somebody who's unfortunately unlucky and that doesn't work and you do progress and you have pathology, we now have options for you. And so we have, you know, tests that can determine the probability, and an easy test such as blood to determine the probability of amyloid you might have in your brain. We can then potentially, if you meet criteria, offer you a therapeutic treatment. And then for those, unfortunately, who either are not able to be treated because they either don't meet eligibility criteria or may be too far demented, then actually what you do have is we have a system that we can provide care for you. And that's this idea of providing collaborative care in with your family and with your primary care provider and the brain health specialist. So I think sort of creating that story for primary care to know that we've got something to help you and help your patients at each stage is really been, I think, the key to what we've been learning and how to really kind of frame this, because, you know, I think, you know, we expect primary care to do a lot, and they are already feeling that. And I think having this conversation in parallel with them, rather than sort of saying, this is what you should be doing, and here's how we can help you frame this story and care for this patient, I think has been sort of probably what we've learned is the most successful piece.
Yeah, very good, succinct learnings. And I really appreciate, you know, in your response, you're really braiding together sort of complex system issues, operational issues, provider education, as well as just provider belief and behavior. And, you know, all of those things braid together in ways that are probably unique in each system. Charlotte, I know, like Nicole, you've been doing research in your health system and spending time with clinicians and understanding clinician perspectives and how this, you know, may work better in primary care. So curious to hear from you what you've been learning over the last few years in this area.
Oh, thank you very much, Tim. Maybe I can take the advantage of a couple of slides. So in our journey towards implementation of the blood test for Alzheimer's disease, we are interested in understanding the perspectives on the implementation from different healthcare professionals. Also because, yeah, as one of the earlier slides shown today is that innovations get adopted very slowly, 70 to 20 years, and that's what we don't want in Alzheimer's disease. We want to accelerate this. So part of our studies is to understand the resistance of the larger community, or also the barriers and the hurdles for adoption. Because we are very well aware that usually you start with a few pioneers, you get some feeling and some confidence in your new test. And that's the normal road, but we don't want to wait like 17 to 20 years. So next slide, please. So we have several activities, and one of them is to organize workshops where we collect the perspectives. And here's a result from a workshop where we use Post-its, and they worked in small groups. We asked them to visualize that there is in implementation in primary care of the Alzheimer blood test. They were neurologists in training. And we ask them to brainstorm freely about the opportunities and the challenges. And these are more or less the kind of consistent patterns that we observed. So the opportunities is like it's cost effective and non-invasive. I think it's a very inspiring one that there is better communication with families. So that pertains to accessibility and equity. And because the blood biomarkers, they can give you an objective indication and that will help discussing the disease with the families. But there are also many challenges. People are clearly not aware of it. So lack of standardization, need of infrastructure, but also result interpretation, what Nicole also already addressed, and the lack of awareness. So I think these challenges, I do think it's quite solvable. We need to address them via education, probably raising awareness. But I think this gives us some leads how to address that. In the next slide. Oh, now there's some nice animations. We also performed a study together with Alzheimer Netherlands, which is the Alzheimer patient organization in the Netherlands. And we wanted to get an insight in the informal caregivers' perspectives towards the blood testing for Alzheimer's disease. Why the informal caregivers? They are more or less familiar with the disease. They are not affected, but as we all are, they are potentially affected in the future with Alzheimer's disease. And I want to share just one result with you, which is on the next slide. Oh no, this is the setup, but that was to be scientifically conscious, because it was a scientifically well designed study for implementation. But in view of time, I leave that for now. The graph gives you an interesting picture. So in the blue bars, light blue bars, you see the answer to the questions. Would you get screened for Alzheimer's disease in the future if there is no treatment availability? And already 57% of them replied yes, they want to get screened. So even if there is no treatment available. Once this changes into treatment availability, then we get a high level, everyone, 99% wants to get tested. I don't think it's screening or what you call it for using the blood test, but it's more about getting an early or timely diagnosis for Alzheimer's disease. So I think it's really a high number, and the population is there. They are willing to use it. And now, we want to understand how the healthcare or how we can change the healthcare system to facilitate and accommodate such testing. Reasons why you could want to have this testing, of course, it's to exclude treatable causes and also treat those causes, but also to understand what's happening to you. So knowing that it's Alzheimer's disease and not that you are, in words of my friend who has Alzheimer's disease and was diagnosed, that she was not crazy. And that I think that's very important for people.
Right. Thanks so much, Charlotte. So I think she did a great job of laying a foundation of the pathway. Nicole, you spoke to the sort of complex operational and clinical considerations in the real world. Charlotte, a lot of really good stuff about attitudes and behavior from different folks involved in care. Ara, I know you've been thinking a lot about education, so this sort of being a key component of the pathway. You've been working in the COI blood-based biomarker work group with Chi and others. So what have you learned as you've thought about what good looks like for education over the last 6 months or so?
Well, thank you, Tim, for the question. And yeah, it was a real pleasure to work with the COI initiatives work group, Workstream C. This was made up of a great group of individuals. I was co-chaired by my colleague, Joan Weiss, and we also had representation from Suzanne Schindler, Elise Perwiller, Brittany Casson, Malas Bustiani, and several other individuals, really sort of representing a very diverse viewpoint perspectives, looking at these issues of how to disseminate knowledge. As I mentioned, I was a journal editor for an Alzheimer's journal, and one thing about Alzheimer's disease is that it is in fact heterogeneous in terms of its presentation, but also in terms of the disciplines that it touches. I think the words that both you and Nicole were talking about in terms of complexity is absolutely essential. And this is something that is very key to talking about and educating that this disease is complex. The medical, the scientific, the social, all of these things come together. And so when trying to put together a curricula around that, our work group really tried to look at this issue from several different points of view. So in putting together this work packet, we actually established a flowchart, sort of, we're calling it a storyboard, really trying to help clinicians, healthcare providers understand the what, the why, the when, and the where, and the who should benefit from using blood-based biomarkers. The work stream produced this idea around 5 major topics. One was really looking at the question to determine clinical suspicion of Alzheimer's disease. The second one is, can we adequately describe AD pathology? The third one was to look at advantages and disadvantages of various imaging and fluid biomarkers. The fourth was a what to know for healthcare providers and clinicians about blood-based biomarkers. And finally, perhaps most importantly, is what does it mean? And I think, Chi really sort of touched on that in terms of getting into the issues around the legal and the ethics. As I mentioned, this idea of, trying to put together an educational campaign or even educational material is very much in terms of the same problems that one runs into in terms of describing healthcare systems. One size will not fit everyone. And so right now, the work stream is actually going through the process of trying to sort of do a first pass of what the media will look like on how we're going to describe some of this information. One of the things that I was sort of thinking about, one of the questions, I think it came from one of the 40 countries represented on today's phone calls, which is absolutely amazing, is how are we going to sort of provide this information? And so during the presentation, I was chatting with some of my colleagues about this idea of really trying to have a bidirectional development of some of this educational material. And so I think one of the recommendations that I'd like to take back from today's call to our work group is to say, we really need to engage more with the worldwide community and start to road test some of our material and get some feedback. So for everybody participating on today's call, this is not information coming from on high. We really do think we need feedback. And one thing that I've learned, again, even as a former editor, is that you can't know everything. And certainly as many eyeballs on a topic, on a problem, is absolutely essential. And so I'll stop there and see if there's some questions, but this, I think, has just been a fantastic morning session today. So thank you again for inviting me.
Thanks so much, Ara. I know that we're running up against time, so in the interest of making sure that we're able to get people out in the time we communicated, I might wrap our panel here, but I just really want to thank everyone for calling in this morning or afternoon, depending on your time zone, and for your insights about this. Really, really good stuff to think about, and we really look forward to talking more about accurate diagnosis in the year to come. So with that, maybe I will turn it back over to George to wrap up and give closing remarks for the day.
Thank you very much, Tim, and thanks to this panel. It was terrific. Thanks to everyone, our panelists, speakers, special guests for this dialogue today. Thank you to everyone who attended. You've heard today about the reach of DAC. We've worked in the healthcare systems, primary care level and beyond to pharmacists and to community health workers and systems in about a dozen countries across the globe with our initial set of programs. We are now working generally in over 60 countries through all of our programs combined, directly and through partnerships, including what will be a close collaboration with Worldwide Fingers. Tanzania, Armenia, Jamaica, South Korea, Malaysia, US, Germany, Japan, the list could go on and on. This reach is critical to achieving our goal, which is brain health for all. And brain health is an imperative for achieving universal health coverage through primary care systems around the world. So engagement with primary care, strengthening the system is critical. Brain health is linked to your physical health and physical health to brain health. What do I take away from today's discussion? 4 things. We have to both think short and long. That is, we have to think about what we can do today to lower the cost and increase the accessibility of the current disease-modifying drugs. But as these drugs develop further, we need to figure out how to continue to lower their costs and increase the ease with which patients can actually get the drug. We have to go earlier. We have to go into preclinical studies, which are now ongoing with these disease-modifying drugs, but to go earlier in that process. And we have to do this together, since none of the sector's governments can do it alone. Second, timely detection and diagnosis supports all of this work. As we go earlier with disease-modifying drugs, as we go increasingly to an integrated system of risk reduction and disease-modifying drugs, all of this early detection, early diagnosis, early risk assessment is increasingly important to be able to prevent this disease. There's an enormous value in what we've talked about today, which is the learning across primary care, across health systems worldwide, and that we ought to continue and deepen this work to assure that we learn together from low and middle income countries, what we can learn from those systems, as well as what we can learn from the high resource countries as well. And fourth, early modification of this disease, early intervention in this disease increasingly important, making detection through blood-based biomarkers, digital cognitive assessments, very much in the short term. Then link that work to both the increasing efforts in health systems around the world. You've heard that we're going to launch a diagnostic program next year. We're about to release by the end of this month the blueprint on early detection, and you've heard that a little preview from Jeremy Mott about the Scientific American collaboration, which will occur in the next couple months. I suggest and recommend to anyone who wants to get in touch with us to please get through us to the Davos Alzheimer's Collaborative.org, our website, or otherwise to Alyssa Kurzman, who I believe sent out all of the alerts for today's meetings. Please contact us if you have any ideas, thoughts, want to get involved. This is going to be a collaborative effort. We have to think shorts, get lower cost DMTs, begin to implement globally risk reduction strategies to prevent the disease, and long to get, as Dr. Suzuki mentioned, a cure, or as I mentioned, a vaccine, but to think that long and how we ought now to be doing what we need to do in order to think about these transformative developments. I thank you all for being here today, and look forward to working with each and every one of you through the Davos Alzheimer's Collaborative to advance our efforts to prevent and knock off this damn disease and to achieve our mission of preventing Alzheimer's. Thank you very much for being with us today, and have a good day.